Abida Kareem is a medical scribe with a Bachelor of Science in Biology and an honors graduate from Virginia Commonwealth University. She's actively pursuing medical school while volunteering at the Children's Hospital of Richmond and working at VCU Massey Cancer Center.
Hi everyone. Thank you so much for that introduction, and thank you for the asset team for allowing me the opportunity to share my review of research here. I'm going to be focusing on CAR T cell therapy, specifically in bone cancer. My name is Adeeba Kareem. I'm calling in from Richmond, Virginia, affiliated with Virginia Commonwealth University. Today, I'll be walking you through the methodology, benefits, and challenges of CAR T therapy, in addition to some personal insight as a medical scribe at the Bone Marrow Transplant Center of Massey Cancer Center. So let's go ahead and get started. Just some background on immunotherapy itself. Generally, immunotherapy is an autologous treatment that uses one's own immune system to combat illness. Some general popular therapies include cytokines, immune checkpoint inhibitors, and vaccines. For the sake of time, I'm not really going to go into those, and I'd rather just focus on CAR T, what we have at hand. So what is CAR T? It stands for Chimeric Antigen Receptor T cell therapy. It's a profound and ever-evolving immunotherapy showing promising evidence in and beyond the scope of oncology. I know we had a presentation before earlier today regarding CAR T as well, but I would like to focus more on the oncological aspects. But just to refresh, a quick summary of what it is its enhancement of the T cells in one's own body to better attack cancer cells. So just some key milestones in the evolution of CAR T. In 2010, we had the first successful human clinical trials conducted by Dr. Carl June, where he implemented CD19 targeted CAR T cell therapy on 3 patients with chronic lymphocytic leukemia. Of these 3 patients, 2 of them reached complete remission lasting for 10 plus years, and one of them reaching partial remission, and that last patient doesn't have as much information on it. This clinical trial was an immense breakthrough in the evolution and study of CAR T and immunotherapy itself, because it was the first, human significance. So since then, by 2017, FDA in America approved of the first CAR T cell therapy regimen by the name of Kymriah, treating pediatric and young adult acute lymphoblastic leukemia, or ALL. Since 2017, 6 total regimens have been approved for various subtypes of bone cancer, though today we won't be focusing on all of them. And as of
Amazing,
August,
Monica.
I'm sorry, what was that?
Good.
Okay, I'm going to continue. So as of August of 2024, over 34,000 individuals with bone cancer have undergone CAR T cell therapy in the United States. Unfortunately, I will preface most of my data is from the United States, but all with the intent of implementing longer-term remission in later stage bone cancer. Now I'd like to refresh us all from earlier on just the methodology of how CAR T works in a clinical lens. We start with apheresis of the patient. I'm going to have my pointer pointing at the little diagrams. What this involves is collecting blood and extracting T cells from the blood of the patient, which is then sent to labs so we can enter step 2. Step 2 is the very important part of CAR T cell therapy itself, where we genetically modify the T cells that are already in our body. What's happening here is that scientists are genetically enhancing the T cell by adding a CAR gene. What this means is a chimeric antigen receptor gene. This receptor is what enhances the T cell's ability to identify and attack certain cancer cells. And that's going to form what we now know as CAR T cells. You're going to notice as I go through this presentation, There are different subtypes of CAR T cell therapy itself, and that's because each of these receptors are going to target different antigens and different proteins on specific cancers, and that's why CAR T is so personalized to everyone's individual cancers. Back to the methodology. After we have that genetically modified T cell, we're going to be amplifying it in the clinic so that we can actually see an effect when we end up re-administering it to the patient. I'd like to take a sidetrack away from the T cell to mention an important step involved in CAR T that makes it such an intensive therapy, which is chemotherapy by the name of lymphodepleting. And what this is basically removal of a good amount of white blood cells in the patient to ensure that there's room for the new T cells without the body rejecting it by its own pre-existing immune cells. So it's basically just similar to clearing out old data to bring in like new and updated software. Finally, at step 5, once we have all the amplified T cells and the patient has undergone sufficient chemotherapy, we will re-administer their own T cells back to themselves um, through through intravenous infusion. And that's what makes them officially on the journey of being a CAR T patient. So I would like to focus on 3 of the regimen of CAR T therapies that are prominent in my clinic at Massey Cancer Center, and they are published on their website. These include Yescarta, Kymriah, and Tecartus. And each of these respectively treat subtypes of large B-cell lymphomas, ALL, and mantle cell lymphoma. So I would like to recognize that a main common ground with all of these CAR T therapies and honestly all cell therapies involved in cancer is that these are second and third line treatments. That means that this is only applicable to patients that have either relapsed in their cancer or they've tried several other regimen and it's just not working. So this is basically has a goal to improve one's quality of life. It's not going to be a cure, but is aiming to prolong remission, improving quality of life, and treating later stage bone cancers. I'd like to just mention some studies that I looked into just to like put some numbers out there. These all used evidence from the Center for International Blood and Marrow Transplant Research, and these included several centers across the United States and collected data and basically like combined it into like one little study for each of these CAR T therapies. I focused on 3 of them. And I'm just going to summarize for the sake of time what this evidence even means. So what we're seeing is in each of these studies that the patients chosen are all in refractory or relapsed stages of their cancer. So for Tecartus, it's mantle cell lymphoma patients. For Yescarta, it's large B-cell lymphoma patients. And for Kymriah, we have ALL patients, and we also have non-Hodgkin's lymphoma patients. Basically, what we're seeing in each of these studies is that we have at least above a 75% objective response. And what this means is that 75% of the patients in these studies have had diminishing activity in cancer cells. And again, in each of these studies, we have above 50%, almost above 60% in each of these reaching complete response. And what that means is patients with absolutely no active cancer after this therapy. That being said, it is not a lifelong solution. So each of these studies did have 7-month, 12-point checkpoints with overall stable objective responses at least. What I would like to point out that's common amongst all of these studies is the drawbacks in them. We're seeing this thing called CRS and ICANS present in a great population of the patients amongst several grades and several intensity, though the more life-threatening side effects of them are only shown in like 10 to 15% of the patients in most of these studies. But that is one of the major drawbacks, which I'm now going to go into explaining. So what are those acronyms even? CRS stands for cytokine release syndrome. What this means is that the immune function in your body is just triggered too aggressively. It would be amazing if enhancing your own immune system was foolproof, but unfortunately, there are side effects like this one. And overdoing it is not the best. What this might look like with symptoms is headaches, shortness of breath, myalgia, arthralgia, and tachycardia. And it's really important when doing patient interactions and patient evaluations to establish the grade of the CRS, so that providers can efficiently implement personalized treatment regimen. ICANS stands for immune effector cell-associated neurotoxicity syndrome. And what this means is that it's again has to do with the immune system being overactivated, and these active immune cells end up crossing the blood-brain barrier, which ends up causing inflammation. What this might look like includes aphasia, delirium, focal deficiencies, and seizures. Once again, the level of the symptoms should be evaluated for better personal care. That being said, thankfully, neurotoxicity is able to be treated, and usually within 1 to 1.5 of the patients at our clinic in Massey Cancer Center have alleviated symptoms of neurotoxicity. Now, I want to talk about how this really looks in an actual hospital. We're seeing all these facts, this like procedure, but what does that actually look like? So I'm going to talk about my perspective of what I've witnessed at Massey Cancer Center in the BMT department. We offer three different cell therapies, two of them being stem cell transplants, which I won't be focusing on today, and then of course CAR T, the topic of the day. So we have three stages, two of them being outpatient, which means clinical visits, one of them being inpatient, which means 24-hour hospitalized care. So starting at stage one, we have the pre-transplant outpatient stage. Here we're doing pre-transplant workups, including pulmonary, cardiac, hepatic, and renal function evaluations. This is of utmost importance. CAR T therapy is a very intense process, and the end goal is, like I said, for improved quality of life. What's going to happen if a patient is not able to handle this therapy is not only is their quality going to be diminished, but so is their quantity. So at our clinic, we really, really hone in on the importance of proper pulmonary function, cardiac function, all of these things. And we don't just turn a patient away. We try and evaluate them for a few months, maybe even years, to see if there's improvement so they can be reevaluated. So at stage two is when all the fun like procedural stuff happens that we're even discussing about today. And this is after a patient has been deemed cleared for transplant. What happens here is the reinfusion procedure that we mentioned with all of the mechanisms, as well as initial recovery. So here a patient is going to be under 24-hour hospitalized care. It is an intense therapy once again, so they have to be closely watched, and their symptoms need to be evaluated to see if it's just a regular symptom from the therapy or if it's another disease or any complications like that. Finally, we have the longest stage of the procedure, and this is outpatient follow-up visits. This is a very complicated procedure with complex obstacles and side effects. That means it's really important for patients, especially at our clinic, to be followed up with and to evaluate everything. Nothing is a small, side effect or a mistake or anything. At VCU's Massey Cancer Center, we have a great multidisciplinary approach. We collaborate with our neuro-oncology, cardio-oncology, and other specialist departments to provide comprehensive personal care to each of our patients. And I would like to mention our BMT team of 5 wonderful doctors who ensure patient safety and make sure every single patient feels like they're important and cared for and followed up with. So I talked about all of this, great evidence, great evolution, but what does this really mean for right now? Unfortunately, it's not a cure. That means that we have a long ways to go, but we are making progress. So, future research might involve combating current drawbacks, increasing efficacy of existing CAR T regimen, like improving the percentage of response rates, and maybe enhancing and increasing the scope of what CAR T is treating, hopefully like solid tumors and not just blood cancers. I do want to talk about some personal experience that really makes me establish where we are in the research of this evolution. Considering I get to witness like actual clinical trials of this going on, I will say it's sometimes heartbreaking, but it's also so motivational when we see the beauty of new clinical trials coming to be. So I want to just briefly mention an experience I had recently where even though we are an oncology and hematology department, we accepted a patient who I obviously can't disclose too much information about, but they presented with sickle cell anemia with crises, and we're implementing a CAR T therapy to alleviate these symptoms. And it's absolutely amazing and inspiring to see how this evolution is occurring right before my eyes. So, in conclusion, CAR T cell therapy has revolutionized the treatment landscape for bone cancer and beyond bone cancer, offering hope where conventional therapies have failed. While there are challenges to overcome, the promise of improved outcomes, longer remission, and the potential for a broader application make this a promising avenue of research. Thank you so much for your attention, and I look forward to hearing any.
A very good presentation. Just a quick question.
Yeah, of course.
So, what is the patient's interest if you have the CAR T studies and also normal studies? Which one patient will choose based on your experience?
So, what I've seen, honestly, are the department I work at, the Massey Cancer Center, is one of the top oncology departments in the area. So usually these people are already dealt with so much bad news. Our doctors really emphasize importance in clarity and transparency, and usually they're good at evaluating what is most suitable. That being said, sometimes the patients can't really choose if it's not applicable. Like, we're not going to let them go through with something they think they can handle, just because that will be on the doctor or the provider's, conscience, and that's their job. But if they do have the option, they usually end up choosing what will most likely promise them a better quality of life. With CAR T itself, there's not really much choice of what type of CAR T to do, because each type of CAR T there is targets a different type of cancer because of the certain receptors. So that's basically what I've seen. Usually it's just the doctor saying, here's your options. Here's the one gene therapy we can do, or you can just continue with like your first line treatments that didn't really work. And typically they end up following through with the stem cell or the cell transplant.
Okay. One more quick question.
Mhm.
Actually, how's the interest of the subject for the long-term follow-up? Because this is very important for the CAR T therapy. You should follow the subject for 15 years at least.
Yeah,
Mm.
I didn't delve into as much in my research of that.
Mm.
But from my personal experience, I've seen patients that have been in remission for 10 to like 15 years. They'll still come into clinic for yearly check-ins, yearly follow-ups.
Mm.
And I've definitely seen that, but that being said, it's not foolproof, of course. So there are still some patients that come back with a relapse. And that's the whole thing with these stem cell and genotherapies is even if it doesn't cure someone, its goal is prolonged remission so that when relapse occurs, we have more choices. We can do another cell therapy and focus on the quality rather than the quantity of life.
Thank you so much. Yeah.